You're welcome to come up here. Good afternoon, everybody. Thank you for being here. My name is Grace Lem. I'm going to be your moderator for this session on intraoperative pain management during cesarean delivery. We are excited to be here, and I'm also not so excited to tell you we are having technical difficulties. So we are going to switch up our presentation a little bit to accommodate a couple of things. One, we need to troubleshoot what's going on with a missing talk, but I also don't want to keep you here any longer than you need to be, so we'll launch on time just a little bit out of order. We're going to start first with Dr. Heather Nixon, who's going to tell us about when to convert to general anesthesia. At some point, I'll have my moderator slides up where I'll be able to properly introduce everybody and tell you a little bit more about the context of the problem and why we need to advance in these areas. Dr. Mark Zakowski, who some of you may know is on a campaign trail running for secretary here at ASA, is also managing reference committees at this time for the very statements he's going to be presenting to you guys today. So he will be presenting at some point. And we will close out with the illustrious Dr. Neil Kalaria, who's going to tell us more about how to prevent these strategies, how to bring intraoperative communication tools into these topics as well, into these conversations as well. So without further ado, I'm going to pass it on to my lovely colleague, Dr. Heather Nixon, who is going to tell us about when to convert to general anesthesia.
Yeah, of course. Okay. Good afternoon, everyone. I hope I don't steal anyone's thunder because I was supposed to be third or fourth, but hopefully I won't take any of that away because I know what they're about to talk about, but hopefully I'll complement a little bit of what they say. So I'm happy to be here today to talk about something that I'm very, very passionate about and I've spent a lot of time talking about, but I actually don't have an answer for you. So at the end of the session, don't think that you're going to walk away knowing exactly what the answer is. This is a very difficult topic, and you would think everyone knows how to do this properly, but we know that we're not actually doing it well. And so I think that, in my 12-minute talk today, I'm going to give you some really pretty images to look at. So that'll be a nice little break from maybe some of the other slides you've seen. And I'm going to talk about a few articles and put some QRS codes about what I think are the best articles in this area that you can take away and maybe really will help you challenge some of the dogma around this concept and really think about it in a new and different way, the way that our unit is starting to look at it. All right, so let's see if I can get us to go forward. Do we have a clicker? Technical difficulties continue. All right, let's do it manually. All right, so I have no financial disclosures, but I am going to disclose that I was part of the podcast, the Retrieval Season 2, which really focused on intraoperative pain and the problem that we're having there. I know many of you may know the name, but the Retrievals, some of you may not. And so this podcast really focused on women's pain being ignored or not being treated properly. And the second season focused on intraoperative pain during cesarean delivery. And that's really the impetus for this talk of what we're trying to prevent. So the two heroines of the story were really Susanna and Clara. Clara is a nurse on my unit who had intraoperative severe pain. And although these are extreme stories, they're not actually that rare, which tells us that we have a lot of work to do in this area. So when we look at intraoperative pain, I think one of the big problems we've had is that we really haven't asked the patient, and that's going to be a theme that comes up in my lecture today. Is that we need to ask our patients. Most of the studies that we had prior to about 3 or 4 years ago were all surrogate markers of failed neuraxial when patients were converted to general or they got IV medicines. But it really didn't capture the patients who were having intraoperative pain and were undertreated and it was under-recognized, and that's what we're trying to prevent. So when we think about intraoperative pain during cesarean in 2025, we actually asked the patient. And this is a great study. It's a systematic review and meta-analysis by Charles et al. And they got the patient perspectives. And really what they found out was that 1 in 3 patients who have epidurals, as well as 1 in 10 patients who have spinals are having intraoperative pain. And so this is the best data that we have to say that this is a really prevalent problem. It is more common than any other complication that we have in anesthesia, or at least OB anesthesia, and we need to take it very seriously. We need to do something different. So again, that's 14% for spinal and 33%, so that's 1 in 3 patients of your epidurals. So what are the problems when patients have under-recognized pain during cesarean or undertreated? Well, we have decreased maternal-infant bonding, decreased breastfeeding, PTSD, higher rates of depression, and resistance to further pregnancy. So these patients are traumatized, and we may not even know. We think we successfully got them out of the operating room, that the baby and mom were healthy, but we didn't consider their mental health in this. We didn't really think about what was happening afterwards. So it's really time for us to start incorporating new ways of thinking about how we administer anesthesia. When we talk about what's being done in this space, the ASA has published a statement that really says that anesthesiologists should be part of the support system, psychological support system for laboring patients and patients who are delivering, that it is part of our responsibility to really make sure that they are okay and what we do matters. So this framework includes support through shared decision-making, good communication, and encourages autonomy. And I know Dr. Lim is going to talk a little bit more about that, so I'll kind of abbreviate my thoughts there. But in order to make the right choices, we really need to look at what we've done historically and what we've said to each other, taught each other, and propagated. And so we need to look at how do we prevent this psychological harm, and we know that we need to confront our own fears and our own dogma about GA in cesarean delivery. It has been taboo, it is something that has been penalized, it is something that has been a marker of poor care, and that's probably wrong. So now we have to open our minds and we have to say, in 2025, what are the real risks and benefits of neuraxial versus general anesthesia? And I think we have to open the aperture that maybe there are more patients who would benefit from general anesthesia than we previously thought, all right? So it is not any longer a avoided at all costs, but let's talk about what are the actual risks. So when we talk about GA, our bias in cesarean is so pervasive that when providers were asked to participate in a study comparing general anesthesia outcomes with regional anesthesia outcomes, many providers said that they couldn't righteously participate in that study because they thought that neuraxia was so superior, right? That tells us something about our own biases that we've created in the field. If we talk about what we know about communication and assumptions, right? We, unfortunately, as providers, are terrible at reading our patients and knowing what's going on for our patients. We are just terrible at it. Study after study after study in the last 4 to 5 years has demonstrated that when you evaluate a patient and you do not ask them, again, that theme of asking them, you are often wrong about what a patient is experiencing. Now, fears for her baby, coerciveness in language, emergency situations may cause her to shut down and not tell you what she's thinking, which means we have to ask, but we're also wrong a lot of the time. Our anesthesia providers attribute pain to anxiety in women more often than in men, and in the labor floor, that's even more prevalent. So when we've blinded assessments and asked patients afterwards, we're often wrong, where we misattribute anxiety and pain. And so we really have to start thinking about how do we get that right? What do we put in place to understand that so that we can have a roadmap of when to convert for general anesthesia and how to mitigate harm? All right, and then let's talk about some of our fears. So when we talk about maternal outcomes, this is one of the things that I will hear the most often is, well, I'm afraid of hurting mom, right? And what are the two things in the middle of a case that you're most concerned about? A lot of times the baby's actually already born, so maybe neonatal is not as much of a consideration. But you have been told, it has been born and bred to you, that the pregnant airway is the difficult airway. It is a big bad wolf. You will lose the airway. Mom will die. Families will be destroyed. And that is part of the problem. So let's talk about what we actually know. And then the other part is the OBs have bought into the idea that hemorrhage is more prevalent in these patients, okay? So what do we actually know? So we have a really good study that came out in I think it was 2022 or 2023, that was the MPOG data, looking at what is the actual risk of failed or difficult intubation in the OB population. This was a huge study, okay? But what they found was difficult intubation was about 1 in 49 patients in the OB realm. Now, these are all comers. These are emergency cases. This is every type. This is not an elective planned intraoperative. This can be really difficult or bad situations, right? It was 1 in 49. That's difficult. It doesn't mean they didn't get the airway. The risk of failed airway was 1 in 808. That's pretty equivalent to what we've always thought the airway was in the general population. And so we're starting to see with the use of video scopes, LMAs, and other things, that maybe that is leveling off, that maybe we're getting better, and that we know that anesthesia-related complications globally are going down, and in the OB world, they definitely are. So maybe when you weigh that against a 1 in 3 risk that a patient's going to have pain intraoperatively versus a 1 in 808, right, that you might have difficulty with, right? Or you might have a failed intubation. By the way, none of those patients had maternal deaths. They were rescued with LMAs. So also know that we have that as a backup, and that's what the second paper really looks at, is what is the use of supraglottic devices in the OB world. And there are places in Europe where they routinely can do these for elective sections. They'll choose to use an LMA. So we need to be not afraid of that anymore as well. It's a good rescue device, and especially the ones that have the oral gastric suction option, right? Which we're always worried about aspiration, which again, if you look at current data, incredibly low in the OB population. I'm not telling you not to be afraid of the pregnant airway. I'm not telling you not to respect it. What I'm telling you is don't fear it so much that you're putting a patient at psychological harm. So when we look at hemorrhage, right, we've been taught, oh, there's so much more bleeding when you have a general anesthesia case, right? That may or may not be true. Right? So if you look at non-randomized studies, there is a significant difference. But of course, those are patients who may be having placental abruptions, maybe have antepartum bleeding. I've already have a reason to be in the operating room or might have emergency reasons to have general anesthesia. But when you take it and you take the studies that are randomized, all right, they took 12,000 patients. They found that there was probably about 100 mLs difference in blood loss. Is anyone in the room going to transfuse over 100 mLs in an OB patient? Is anyone going to send that patient to the ICU? Does anyone consider that major morbidity? No. But is permanent psychological damage disability? Yes, it is. So we need to weigh that again. We need to understand that that's what the real risk is. Although the numbers say there's a difference, clinically it's not relevant. All right. Neonatal outcomes. So I can't leave this part out, right? And I want to say that there's a brand new article, okay, that you really need to read. Take this QRS, okay? It is going to be talked about, and I'm hoping it will be. This is and of course, Dr. Lim, thank you for your work here. This is about neonatal outcomes versus regional versus general, and it's a meta-analysis of randomized controlled trials. So how did the babies do, okay? If you read just the conclusion, which I think your OBs probably will, your neonatologist will, you will see that there's a statistical difference between APGARs, 1 in 5 minutes, in patients who have, or neonates who are exposed to general versus regional. However, that difference is 0.58 in an APGAR score and 0.09 at the 5-minute. Does anyone care about 0.09 change in APGAR at 5 minutes? No. It's not clinically relevant, even though it's statistically relevant. Now, these babies do require a little bit more of respiratory support, but if you have the right people in the room, they're not admitted to the ICU more commonly. So this is probably an acceptable risk, and it's something we need to counsel our patients on. So what can we do differently? That's what I'm going to say today, because how do I answer the question of when do we convert to general? Well, I think it really starts outside the operating room, because you need a roadmap with your patient. You need to ask your patient, right? You need to have the very uncomfortable conversation of, you're going to the operating room. We're going to have neuraxial anesthesia, whether epidural, spinal, whatever conversations you're going to have. Here are the risks and benefits of that. However, 1 in 10 to 1 in 3 women will have intraoperative pain. It is my job to treat that, but I have to know you're having it. I have options, and they include giving you more epidural medicines, giving you IV medicines, up into including general anesthesia. That is a conversation that should not be had in the operating room whenever possible. And this is a conversation that I now have with every one of my laboring patients after I put their epidural in. I say, now I deal in the what ifs, and I need to talk to you about the what ifs, right? And then we reiterate that when we get in the operating room. But if we re-examine this and we look at kind of what patients want to know, they do want to know this. This was a qualitative study looking at their experiences, and it really kind of highlighted that they wanted to know about this risk. This is not something to avoid to make it more pleasant for everyone, to make it focus on the happy ending for the baby. This is real medical risk and benefit. And so we need to have this conversation. So, and when we're having these preoperative conversations, 2 questions that I think are really important is, what's your highest priority for this delivery? And is there anything you're afraid of? Those are the things that are going to help you with this roadmap. Because if your patient says, I'm most afraid of experiencing pain, that's a patient who is way more likely to have PTSD, right? Than someone who says, I am most focused on that my baby's health is okay, right? And it's okay for them to have those views, but you need to know what they are. If you don't have those conversations, you don't know what their priorities are, and you don't know if they're at risk for real complications. So how do we successfully convert, right? We have to be ready. So preparation is the hallmark of anesthesiology, having the right persons, the right medicines, the right equipment, and the team. We live, breathe, and die by this mantra. So we need a team that's ready, all right? We need our nurses and surgeons to understand that the issue, part of them is their issue, that they are part of the solution, that they are just as responsible for patients' pains intraoperatively as we are. Right? The surgeons need to stop the surgery if it's allowable, and we need to allow safe conversions, right? So we need to have our best shot at being able to convert. Medically prepped. So if you are concerned about aspiration in your patient, give metoclopramide. It's a great drug for OB patients, right? I see people who avoid this because they think the patients are going to get disinhibited. If you are really concerned about aspiration, this is something you should be giving. Position the patient on the bed, right? Take the time to position the patient properly. And if you have to convert intraoperatively and they're not optimized, stop the surgery, move the patient, and get ready to take on the airway, right? We can be less afraid if we have a better shot of being successful. Have the video scope close or outside. Many institutions are using it routinely. I recommend that. I've been using it routinely since 2012. They are mounted in our operating rooms. We use no other type as our first go. Okay. And then you need an anesthesia helper. And I really have found that there's a huge difference between academics and private practice. And I work in both settings at this point, where it is incredibly comforting to me in my private practice setting as I'm having this conversation about converting with a patient when the charge nurse rolls in behind me with a video scope and stays at the head of the bed. So if you don't have an anesthesia helper, if you don't have a resident, a colleague, or someone who's in-house, you need to create a system where someone can help you and help you in a meaningful way, that they know how to help you in the same way that they know how to help the surgeons, because it does take on risk. And then information and communication. So let's recognize that historically we failed our patients. We tend to, in order to really make patient-centered decisions about when to convert, we need information. So in our unit, we use intraoperative pain scores. If you've listened to the retrievals, you know that. And every 15 minutes, we ask the patient, what is their pain score on a scale of 0 to 10? It is only so that we can have a shared taxonomy. It is only so our anesthesia providers are not looking at the patient and misjudging their pain. And it allows patients, by telling them, we're going to ask you and we want you to tell us, to feel more free to say it instead of suffer through it. And that's what a lot of women will say. Well, I didn't think I could say anything. I thought that was normal. They kept telling me it was normal. And so I just figured I'd endure it, right? So this allows us to have shared expectations. And in order to work through this, you know, we enter the operating room and we basically say, we're going to ask you every 15 minutes because it's important to us, but only you know what pain you're having and if it's okay for you or not. We also explain and give them the expectations about what is normal and what's not. So it is normal to feel pushing and pulling and tugging. It is not normal to feel pain, and there are treatments for that. That's a conversation that needs to be had immediately, because patients will then tell you when they're in pain, and that decision to go into general anesthesia will be much quicker. So let the patient lead you, but also guide them. Make it okay for the patient to say, I want to go to sleep. Many patients describe that they felt pressured to stay awake, or they were told, well, don't you want to be awake for your baby? You want your partner in here? That is coercive language, and we need to eliminate it because we're trying to exert our own goals. And then finally, just as summary, we need to recognize our limitations in our neuraxial procedures. We need to know that they do not work for a lot of the patients, and that's okay. We need to change our strategies. We need to change our communication strategies. We need to design safety systems for GA. We need to create a culture that normalizes conversion, and we need to ask the patient. If you do these things, you will easily walk down the path that is right for your patient, which is what I'm hoping that after this kind of gives you some guidance to do so. Thank you.
Thank you, Dr. Nixon. Perfect. Thank you. I appreciate it. So good afternoon again, everyone, and thank you for bearing with us while we worked out some of those details on our slides. And thank you, Dr. Nixon, for that amazing introduction into sort of the reasons and rationale behind, how to and when to convert to general anesthesia. So as your moderator, I know we went a little bit out of order. I'm going to back up a little and kind of zoom out and talk about why advancements in this area is necessary and how a shift in the conversation about the way we think and talk about and also research new evidence in this field is extremely very important. I think if we are able to execute on that, then we can truly advance pain management beyond these incremental tweaks in patient care. And so here's what the challenge really is that's in front of us. Cesarean delivery is the most common surgery performed in the world. Neuraxial anesthesia is overwhelmingly the technique of choice, but despite the modernization of these techniques and the great advances that it has afforded in terms of normalization of the cesarean birth and many other benefits, pain outcomes we know are not uniform. Some patients do very well, others experience significant intraoperative discomfort or inadequate anesthesia management or postoperative pain control. And so most of our advancements so far have been pharmacologic with better adjuncts, with the recognition of mu-opioid receptors in the dorsal horn, has really revolutionized the way that we manage and treat pain. But these gains are plateauing, as Dr. Nixon has mentioned, while patients' expectations are shifting. And so this is the gap that exists and where we need to focus our attention in the next 30 years. So to set the stage, I want to offer this very simple framework for what it really means to advance pain management for cesarean delivery. At the center of it is our patient, because ultimately advancement is not just about how we do our jobs better and how we execute better in terms of good adjuncts. It's also about what the patient experiences and the outcomes that they define that are important to them. And so around that are 5 key dimensions that we'll explore very briefly today. First, we start with the mechanistic and pharmacologic foundations. These are the clinical tools that we rely upon. Then we widen the lens and include the intraoperative experience and communication. Dr. Calario will talk a bit about that. And then finally, postoperative recovery and longer-term outcomes. That is an area that we have not paid much close attention to, but really is the area of focus for us in the coming years. And so beyond this clinical lens, we really have to think about that outer rim as well. The systems that we operate in, and this equity layer, how care is delivered consistently and fairly, regardless of where you are presenting for care. And so cutting across all of that is our commitment to patient-centeredness and expectation alignment. So thinking in this multi-layered way is what will help us move forward away from these incremental tweaks to what we do at the bedside to more of a holistic and forward-looking vision of pain management for all women everywhere. And so, of course, pharmacologic innovation really is still important, and it still matters a lot. Neuraxial adjuncts like intrathecal morphine, alpha-2 agonists, we still need to do research in these areas. There have been key advances there over the past 2 decades. Lots of high-quality clinical trials and meta-analyses showing that these are important, prolong the duration and quality of analgesia, lots of benefits both for maternal and neonatal outcomes. However, the real opportunity that exists here is in tailoring, recognizing that not all patients are the same and not all cesarean deliveries are the same. Obstetric factors like fetal station, duration of labor, chorioamnionitis, urgency factors, these are all things that factor into the surgical and pain experience. Patient factors like body habitus, anxiety, prior psychological or mental health disorders, prior operative history, these are all things that are going to influence what you're going to do from an individual management and dosing perspective. So evidence-informed personalization is a frontier, and we need to push into that if we're going to make key advancements in these areas. We know that pain is not purely nociception. It is profoundly shaped by psychological and social factors. And so that means antenatal education, shared decision-making, these expectations, conversations, very powerful, but currently underutilized tools. So we should be measuring what matters to patients in these contexts, right? So patient-reported outcomes provide insight into their experiences that go beyond the VAS pain scores, which we have traditionally been seeing as our outcomes of choice. And so it was in part because of this lack of information on what is important to patients and what defines patient-centered cesarean delivery anesthesia care that we assembled this thing called the Elevate Project, which is a multi-phase patient-centered initiative aimed at redefining cesarean anesthesia care. We integrated patient priorities, lived experiences, and clinical priorities and perspectives to improve communication and outcomes. And through this project, we have learned definitively of many things, but one of the key things we came away with from this project was that patients often value emotional support, communication, and that feeling of safety more than as much as, if not more than, the technical aspects of care. Did I get into the OR on time? Was the baby out within 5 minutes of a decel? Which are things that clinicians really care about as metrics of success. None of these things are more important than other. They're all important. The question is, how do you integrate all of this into a whole picture so that everyone's on the same page about what's important in that situation? So advancing pain management means that you're going to bring those patient priorities into how you deliver and plan and evaluate successful care. I would say advancement is also about what happens in the room. So structured communication, active engagement, collaboration, with doulas or support personnel, the bedside nurse who's formed a several hours long relationship with that patient versus the 5 minutes that we might have just gotten a chance to, forge with that person. So what we learned through Elevate is that there's a striking disconnection between what patients and providers are prioritizing during cesarean delivery. Providers are often focusing on the technical aspects of care to define success. Patients are emphasizing presence, communication, and emotional reassurance. And so these mismatches are important. They are not trivial. They are directly influencing perceived pain and risk for psychological harm. And so addressing them is fundamental to advancing care. And this is, before we talk about post-operative outcomes, I want to zoom in a little bit and talk and recognize, a little bit more of this importance about the differences that exist between patients and providers. We often have different priorities, and that is not a good or a bad thing, but it is important to name it. So this is a figure from a recently published paper from Clifton et al., and it's essentially showing how patients and providers are very different with respect to, what we are valuing. Patients are ranking the baby's safety and respectful participatory care. That's what's first and foremost on their minds when they're entering that room. Providers are thinking about the technical aspects of care, timeliness, clinical factors. They are also thinking about the patient's experience, but it is not falling in an area that is as high as what the patients are considering. And so the differences are statistically robust, and until recently they have not been systematically studied or acknowledged. And so this is a critical gap because innovation in this area will need to start from a shared understanding that the priorities are different. And so therefore we need to recognize that difference exists and then work toward how you integrate that into a holistic model of care. Our qualitative work is complementing the findings that patients are consistently emphasizing communication, emotional support, trust in their care team, whereas providers are once again focused on the complexity of care, pharmacology, procedural execution, lots of complex things that are equally important. But these perspectives are, I would say, once again, not in opposition. They are different, and they shape how we approach problem solving. And so because that gap has been under-recognized up until this point, we maybe have been stuck in this dichotomy, a false dichotomy, I would say, in terms of what the patients want versus what providers want. In order to advance intraoperative pain management, we just need to acknowledge those differences exist, but intentionally bring systems together to bridge the gaps that exist there. So pain management does not end in the PACU. We need longitudinal outcomes like functional recovery, bonding, breastfeeding, and mental health. And patients tell us that that is important to them. So we learned that in Elevate. They care about pain management. They also think, importantly, we need to measure the mental health outcomes and the feeling of support and agency just as much as pain outcomes. And then finally, true advancement requires systems-level thinking. So protocolizing pathway is intended to reduce variation, ensure evidence-based adjunct use. And so this is important because it's important to embed equity in this way. Racial and language disparities in pain care during cesarean delivery have been very well documented in lots of studies. And so in order to address that, you're going to need to design systems that deliver high quality, equitable pain management to all patients, possibly through these types of standardized approaches, which allow for individualized and tailored decision-making when necessary. This is my own time telling me to speed it up. And so advancing pain management for cesarean delivery is going to go beyond doing better with our regional blocks. That's still important, but that cannot be the only area of focus for us anymore. We really need to start talking about personalizing through humanizing the intraoperative experience, focusing on longitudinal recovery and outcomes that are way beyond just the physical, and then once again thinking about how we embed equity in systems level thinking. If we can frame shift in this way, then the pharmacologic innovations that we do are going to have their greatest impact because we'll put them into the context of care in a more human way that center the patient. So thank you. And in summary, this is going to involve both science and humanity. And with that, I want to introduce the remainder of our session speakers here. Dr. Mark Zakowski will speak next. He's a past president of SOAP and a longtime chief of OB anesthesia at Cedars-Sinai. He's going to review the most recent ASA statements on pain during cesarean delivery and adjunct use. Dr. Heather Nixon, you've heard from already, who's given us a great talk in terms of when to convert to general anesthesia. And finally, last but not least, Dr. Neil Kalaria is going to talk about the focus on prevention strategies, intraoperative neuraxial management, follow-up, and patient communication. I'm very excited to pass it over to them here. Dr. Zakowski.
Well, good afternoon, and it's great to see so many people here. I have a tradition of photobombing the audience. Let's get the energy up. Say cheers. Okay. Anyway. So we're going to talk about the ASA statements on pain and adjuncts for cesarean delivery. We have learning objectives to learn about it. Pain during cesarean. Who knew it was such a difficult, common problem? I'm going to delve a little bit into the history and how we got here and developed the ASA statements. But pain during cesarean occurs much more frequently than we thought, 15% to 23%, which means almost 200 people a year in the U.S. experience pain. And with a worldwide rising C-section rate, that has tremendous downstream consequences. We could see the C-section rate internationally, and while we're running around 1 or 2%, it's even higher in some countries. So how did we get here, right? The old paradigm was don't give anything that could cross and depress the baby, whether it was directly through the placenta or in the breast milk. Don't sedate them so much they aspirate, and just to point out, it's not a zero risk, although it's low, but 3% of the ASA closed claims aspirations were obstetric patients. And of course, don't give them so much you get a high neuraxial block, which is of course defined as ventilation, not total spinal. The new priorities, we have a greater perioperative long-term outcome of how we can improve maternal and neonatal health. That includes shared decision-making. And we can reduce disparities at the same time. The first paper to really identify this as a huge problem was Kinsella in 2008. And I remember looking at it and thinking, what? This is so far from my perception of reality. It took a while, as sometimes happens, for everyone to pay more attention. And as was commented before, right, when we were taught in the old days, oh, it's not pain, it's pressure. And that's no longer a valid model of assessing stuff. At what point is a little discomfort, whether it's pain or pressure, become enough that you need to treat pharmacologically or otherwise? Should we be scoring them? And I know Dr. Nixon is a leader in recording intra-op pain scores in the EMR so you can know to treat and evaluate it later. And that term I've been talking about for 20 years, psychoanesthesia, which is no other place I think that we regularly work that there's such a high degree of anxiety, right? I mean, at my place just so happens to be the mean age at delivery is 35. So a lot of people have undergone, artificial reproductive technology in some form. And, this is something that has a lot of buildup. And it's not just about the medication. So we trained, it was about the medication, here's the opioid receptor. We can give something to block it or to, occupy the mu receptor. But there is so much more going on. Not just the pharmacogenetics, which was trendy maybe 10 years ago, but the psychologic aspect. And the patients, there's a lot of history of depression, history of trauma, personal trauma, intimate partner violence, or even abuse, not to mention if you're exhausted, it's middle of the night. And then when you have chorioamnionitis, you have elevated cytokines that also affect pain. So first one out of the gate was the OAA, and I do want to give a shout out to a patient who had experienced significant pain during her cesarean over in the UK, Susanna Stanford, who I got to know through the Corey project. And she single-handedly kept encouraging members of the OAA, oh, we need to address this. And, you know, my shout out to her for bringing it to everybody's attention. And since then, as chair of the ASA committee for OB anesthesia, I picked up on, you know, I follow a lot of information feeds and said, oh, we need to be early on this. So we had a statement on pain during cesarean delivery, and the next year to normalize your ability to go to your hospital and say, well, I want to give epidural dexmedetomidine or whatever you want to give. ASA says it's okay because they'll tell you kind of sometimes no. And then providing psychological support. So these three statements, I do encourage you to look in depth. I will cover them very superficially as some of the materials covered by our other speakers. So there are 7 domains of best practice, and we'll go through them one by one. So preoperative assessment, right? Pay a little more attention in terms of who's at risk. You know, high BMI, it's less reliable block, pain prior to cesarean, fear, chronic use, even having a low epidural when you convert from labor to C-section and you're trying to push the level up, but a lot of it's going down to that caudal space, breakthrough pain. And of course, the faster the OB is urging you to go on, then you don't have time to give more and figure it out. And again, we're going to, I believe someone else is covering some of the risk factors, but, you know, monitor your labor epidural, replace it early if inadequate. Shout out to the people who do OB somewhat regularly because there's a better rate of it not working. And the faster, again, that the OB is saying, oh, I need to cut, the more likely it's not going to work. Don't forget to use some kind of adjunct, fentanyl, maybe epinephrine or something, and then check the level. Disappointingly, there is no good science for how I check the level. Is it going to be surgical? I do like the fact that the OAA, they use a standardized cold ethyl chloride spray rather than I'm just doing the alcohol swab because it's cheap in there. But again, if anyone wants to do a project, this is a good one. Third category, third domain in the original statement was supplementation. Again, key point, no one way will cut it because how you got there and what all those factors we saw will affect what you need to give to adequately, quote unquote, treat it. Whether it's giving, if you have an epidural, more local, there is a couple studies that reference just using some 3% chloroprocaine intraperitoneal for short-term rescue, and separating out, of course, the pain versus pressure and anxiety, which is a separate treatment. And then there are a lot of different ways. And ask the patient. A lot of times they would rather have some pain discomfort than get something, even though you may disagree from your medical mindset that, oh, there's going to be no problem. Once they're on the table, belly's open, there's no time to educate the patient that, oh, this is safe, it won't go to the baby or it won't go into the breast milk. So, and then I summarized some of the materials in the statements to make it easy for you. But if you have an epidural, there's a bunch of stuff you can give. And if it's intrathecal, which you would have to, of course, give ahead of time, things you can give with the onset, offset. Again, it's important if the patient is experiencing to acknowledge. The number one thing that increases sort of psychological trauma is being ignored, feeling dismissive. Oh, I told them and they told me, oh, it's okay, honey, that's not pain. So, you know, acknowledge it, make some shared decision making, right? Help the patient, give them a choice. Would you like something, or is it okay, and take it from there. And we may not be quite as good as we think about. Can you tell that they're having pain? we had false negative 50% of the time, and the only reassuring thing about this study is that the OBs were even worse. And really, again, to give credit to Dr. Nixon and others who are starting to document intra-op pain, at least record the level, and then we'll get you thinking about what's my level, is it normal response, post-spinal or after I give the local, to get a level and document it. This is what the statements actually look like. So again, intended to inform of the problem, educate, and provide background and some reasons why. So it's intended to help you utilize, take it back home. I take in a month, I take the ASA statements that are passed and I bring it to our performance improvement committee so that I try to get our practice aligned with the ASA recommendations. And of course, vigilance, make sure you give enough, check. So for conversion to general, right, the failure rate is going to be 5% overall. And I know Dr. Nixon talked about some of this. How to conduct it, there's some guidance there if you need help in justifying getting, for example, high flow nasal cannula or a video laryngoscope on your unit. And really follow up and referral. Again, if there was significant pain, make sure you post-op them and say, oh, we gave you the medicine, unfortunately it didn't kick in on time because the OB really needed to get the baby out. We're sorry, and talk about it so that you acknowledge, discuss, get some feedback, and then if they're really stressed, refer to a mental health professional. I'm fortunate, I'm in a big center at Cedars-Sinai. They have a psychologist linked to the OB department, so you can just send them the referral. And then quality metrics. If you really want to improve it, of course, you have to measure it. So these are some ones we suggest from ASA. The obvious general anesthesia rate. It is very difficult to know when did you give too much, because was it appropriate? Is it IV fentanyl, a little of this, a little of that? At what point is the patient response to that? So I like to provide alternatives. I look a lot to the UK, the OAA, Royal College of Anesthetists. So they had an epidural failure rate of 13%, and they picked their QI metric as less than 15. So, that's a good start. Replacing, again, 15%. Pain relief, 45 from start of neuraxial. At sub-centers of excellence is check on the patient, every 3-4 hours to make sure they're comfortable. And I really like the way they define this in the UK, which is rather than here in America, I reference ACOG, Practice Bulletin 116, management of fetal heart rate tracing all the time, where category 1 is normal or reassuring, 3 is abnormal, and the only thing it means is increased chance for fetal acidemia. And they admit that 30% of their members were not doing it within the 30-minute skin decision to incision time. So they pulled back from that and did use some vague terminology, but that there was no difference in outcomes. Here, at least, category 1, immediate threat to life for mom or baby, 30 minutes to delivery, and then some compromise, not immediately life-threatening, 75. So I think that's a better conversation sometimes is, do I have 5 minutes to dose the epidural more or not, rather than fighting over, creating conflict over, well, it's a category 2 that they've been watching all night, now it's office hours. Anyway, that's some of the backdrop. Thank you very much. Go visit the Chihuly Museum in Seattle. It's pretty.
Thank you, Mark. And now I'm going to invite Dr. Calaria to give his portion of today's panel on prevention, intraoperative neuraxial management, postoperative follow-up, and communication. Dr. Calaria.
Hey there, everyone. First, I want to start by plugging SOAP, which is an incredible society of OB anesthesia and perinatology. We'll have our annual meeting in Montreal next year. So if you want to learn more about any of this, I think it's a great conference for everyone to consider going to. But a lot of what I'm going to talk about today is bringing together these different topics that we've already covered. A lot of it really focuses on how I do it in my practice. I work across 3 different institutions, a academic center, a private practice institution, and then a low birth rate birth center with CRNAs. So I have resident CRNAs and hands-on, typically all in the same week. So what do my practices look like to help prevent intraoperative pain as well as manage it? And what kind of follow-up do I have? So these are kind of the objectives that we're looking at. I think the first objective here, the assessing labor analgesia function, is probably the most important thing that we can do as anesthesiologists to help prevent this problem, because prevention is probably the most important thing we can do. Now, when we look at labor analgesia, what are some of the risk factors that we look for in a failed conversion? There's some of the things are late placement, so that's someone who's getting a labor epidural or labor analgesia late in their labor course, a patchy block, someone who's had repeated top-ups. If the cesarean indication is urgent or emergent, and then the operator experience, so a more senior provider. How I look at it is according to the SOAP Center of Excellence guidelines, which is nursing assessment every 1 to 2 hours with a pain score, and then an anesthesia provider checks on all blocks, typically every 3 to 4 hours. That's a big ask, I think, for people in private practice where we're by ourselves, but the amount of times where things are caught with this level of assessment is just, it's incredible how many times we're getting passed off on blocks that are patchy, that have been just babied for a while, and someone who's been laboring for a while with a bad epidural is probably someone who's headed back to the OR pretty soon as well. So we really kind of being proactive about it is super, super important here. And then when we do convert, I have a pretty stepwise process. Whether it's urgent or emergent, it's all pretty similar in how I convert a labor epidural to a surgical block. The first thing I do is I do an immediate assessment. If I've been doing my rounding, I know which epidurals I'm kind of worried about, which ones I'm not. I also confirm with the patient that they've been comfortable in that moment. I check with the nurse as well, because those labor nurses are an incredible resource of information. They really can tell you what's been going on with the patient with their epidural, if they feel like they're convinced that it'll work or not. But if I have time, if it's urgent, I do an exam in the room. If not, I base it off primarily questions. And then I aspirate the catheter, start infusing my lidocaine, epinephrine, bicarbonate solution. 5 in the room, 5 at the door of the OR, and then transfer the patient to the operating room table. Typically at that point, I wouldn't give more than 10 mLs without being confident that this is going to be a appropriate block. So what I tell my residents when I work with them in the CRNAs is, if it's less than T10, we're not giving any more. It's just going to make repeating the block more difficult. If it's above T8, we're going to continue bolusing it until we get an adequate level at T4 to T6. We also always use adjuvant, so we use epinephrine and sodium bicarbonate, like I said, but all of our patients will typically get 50 to 100 mics of fentanyl. Something that's kind of new that we've started increasing the use of is dexmedetomidine and clonidine epidurally to help with conversion and that visceral sensation. These are all pretty important things. What Mark talked about with the ASA guidelines, I think that's a great resource for identifying what epidural adjuvants you can have or should have on the unit. I think clonidine and dexmedetomidine are probably the ones that are not as commonly on the unit and really could add a significant additional resource for you guys in the future for converting. Now, if a patient starts So I think also continually assessing in the OR about how our block is working is important. So, we're looking for a motor block, looking if they don't have a Foley, if it's being inserted, was that uncomfortable? The prep solution should feel cold. These are all things that are happening without you that you can kind of assess, watch the patient. I'm typically talking to them regardless, and looking for signs of discomfort. I always do pinprick. I know we talked about cold. I always do pinprick before draping as our last conversion. And I know we talk about the Alice test a lot, but by the point that we do an Alice test, I should already be confident that my block is working appropriately, or I've already come up with a plan to change to some other type of neuraxial or general anesthesia. When I place epidurals, we kind of touched on it before, I always consent patients for general anesthesia, typically as they're getting comfortable, and I'm waiting in the room for a couple minutes for them to get comfortable, about what would happen if we needed a cesarean delivery. It's not typically the first time that they're going to be hearing about cesarean delivery. I know that was always something that our CRNAs and residents were kind of anxious about, is no one wants to talk about cesarean when they're in labor. So it's not the first time, I promise you. They've all talked about it with their OBs. And so kind of talking about what that looks like. What does general anesthesia look like in the operating room? Who can be there? Where does the baby go? When can the partner see the baby? What will they remember? What will the recovery be like? Leaving a lot of time for questions is really important. So building that rapport just from the get-go of every encounter should be building additional rapport and comfort in knowing that, or having them know that you know what you're doing. I also use a lot of nonverbal cues in assessing patients in the OR. So changes in tachycardia, which is tachycardia, changes in heart rate, a very non-specific sign, but a lot of times patients will feel shame about reporting intraoperative pain, which is not something they should be doing, but happens a lot. They feel not empowered to say something. So prompting it, asking how you're feeling, how your pain scores are throughout the process, looking at what the partner's doing as well can often be a good indicator. They know each other pretty well. I look for the white knuckle sign if they are grabbing the armrests, if they are squeezing their partner's hand so tightly that it's white. I ask about pain as well to see. We also have the epidural in place typically if we're doing an intrapartum section. So top-ups early are always a good sign, see what that is. And always making general anesthesia not a scary option. Something that I've also started using is visceral pains tends to be a significant contributing factor to the intraoperative pain. Using intraperitoneal chlorprocaine, it's a quick bridge. Typically, when I use it the most is when there's uterine manipulation. And although there are some RCTs and meta-analyses about these, it's still kind of being developed how we're using it, how it should be used. So the way that I use it is typically 30 to 40 mLs of 3% chlorprocaine, have the OBs instill it into the abdomen. Onset is typically 30 to 60 seconds. So if you're not seeing relief of those symptoms really quickly, I would say move on. But it'll get you through to the point where the uterus is back inside and can continue the surgery, and that visceral sensation is not as active. So like I said, talking to the patient throughout this entire process, when they get their epidural, when a C-section, intrapartum C-section is called, in the operating room, building that rapport, building trust, finding out what they want from this process, asking questions about their children, about whether they want to see the baby come out, just helping figure out what their plan is and what they want. I think on labor and delivery, we deal with anxiety a lot. And anxiety and pain are kind of intertwined in such a interesting way in that we attribute a lot of pain to anxiety, but then fail to treat anxiety as well. So we want to tease those apart, see what we can do to help make the entire experience positive. Also, debriefing with our teams is really important. We've built a lot of our protocols based off feedback from our obstetricians, from the nurses in the room. When we convert to general, we now have a nurse. When we call out that we're going to convert to general, we always have one of the labor delivery nurses at the head of the bed, just to help facilitate the process. And that was something that was born out of just having general anesthesia, people being afraid of converting to general anesthesia just because they felt like they didn't have support. And so, in summary, labor analgesia assessment is going to be a key process in reducing intraoperative pain. Utilize your adjuvants, utilize other options like intraperitoneal chlorprocaine, and then communicate with the patient, with your teams, the obstetricians, and your labor nurses. All right, thank you.
Thank you, Neil. I think at this point, I'll invite our panelists to come sit closer to a microphone, and we have time for maybe 1 or 2 questions if anyone wants to move to the center mic, speak clearly, and I'll try to repeat if the mic isn't picking up.
I guess this is a quick question for Neil. You talked about using dexmedetomidine to convert to a surgical anesthetic. How much do you use?
So the ASA guidelines are for 0.5 milligram per kilogram to 1 or microgram per kilogram. So typically half. I start with half or even a little bit less than that if I'm using another adjuvant like fentanyl.
Thanks. Other panelists?
The guideline has a wide range based on what was published at the time, but I've been using it clinically a lot, and 10 mics epidural is probably a good place to start.
Yeah. 5 to 10 is what I usually use for a labor epidural if I need additional coverage with a labor epidural to top up.
And follow-up question to our panelists, side effects that our audience should look out for, and then if they don't have access to preservative-free dexmedetomidine, what equivalent might you suggest with respect to the alternative clonidine in terms of dosing?
Yeah, so I use clonidine because my pharmacy was much more comfortable with the amount of literature that was published at the time when I implemented it. So all of our patients get 75 mics of clonidine with their epidural conversion. You can see a little bit, they sometimes are a little bit more hypotensive. I have longer cases, so you see that for a little bit longer as well. Our cases tend to be like around 2.5 hours, which is sad, but it's true. So they're on phenylephrine maybe for like the spinal part of it. So I give her both for spinal and epidural. But the other part is that both of those agents have been associated with decreased shivering. So the patient experience is a lot better. They prefer that versus they don't mind being on the phenylephrine. So since I started using clonidine, I don't have any shaking patients.
Thanks, Dr. Nixon. Yes.
Hi, thank you all. That was a really great and really important topic. This is directed towards everybody, but Dr. Nixon, you spoke in your podcast about how you don't use the word pressure in the OR. And ever since then, I've struggled to not use it because sometimes when I'm trying to set expectations with my patients about what we expect them to feel, what we don't want them to feel, I struggle with that. So I just was curious how you talk to the patients about it without using that word.
Yeah, so I think, the quote I have is pressure became a dirty word because it became an excuse to ignore pain. And so that's the key component of it, right? So when I talk to patients and I set expectations at the beginning, so as I lay them down and I'm prepping them, I say, okay, let's just review. We've already talked about this, but let's review what you can expect to feel because you may feel things. You can feel pushing, tugging, pulling. You might even feel some pressure sensations. The key is that it's not painful. If it becomes painful, I want you to tell me. Some patients experience this as weird or odd or strange feeling. If you're okay with that, that's all right. If you're not or you're anxious by it, I can give you something for that. But I need you to tell me these things so I can give you the options to treat it. And so I think that's it. And then I my OBs, I've trained them to actually say, you're going to feel a lot of pressure when they deliver the baby because you're going to feel a lot of pressure. And I usually say to them, this is going to be short-lived. You're going to feel like someone's sitting on you because they actually are. And then the baby's born and then that goes away. I cannot block that fully, but it is short-lived and that will not remain. So I think it's really good to kind of set the full expectations. Like I say way too much. I talk way too much in the OR, but I tell them from start to finish what to expect, because the last thing you want is someone who has a blue drape in front of them who doesn't know what's going to happen, have someone sit on their abdomen and go, like now it's happening. I was told this could happen. I knew this could happen. And now it's happening to me, right? That's not what you want it to happen. You want to go, this part is normal. Is it painful? Like, no, it's uncomfortable. And having been through it, I would say it is uncomfortable, but it is usually short-lived and you can't fully block that. I don't care how good your epidural is for everybody. Like some women will feel it. Some women will say, I feel nothing. But I think that is the way that I use the pressure sensation. And I never, never, never allow the residents to say just pressure, because that's where you get into the trouble. That's the narrative that we used for years and years to dismiss patients' pain, or to say it's normal, to say that it's okay. And it never was.
Thanks, Dr. Nixon. Other thoughts from the panelists on communication tools, techniques? What toolboxes can we send our audience home with today as it relates to that?
I think when I start a shift, I check on every epidural personally. I think that's a key focus, is knowing who your anesthesiologist is every time. Is just introducing yourself from the get-go. Because when you have to run into that room, when you have to run into that room for an emergency, they know who you are, they know what your role is, and that you've been checking in on them and taking care of them at that point already.
Thanks. I think we have time for just one question and then we will adjourn.
And just really brief. I just really wanted to express my gratitude to all three of you. I personally, as an anesthesiologist, as a patient, experienced the absolute worst pain in my life during the delivery of my twins during an urgency section. And I never thought I would become one of that statistic. So without going, I know we're short on time, but what I felt was 100% pain, no doubt about it. What would you say to a woman, granted, I'm an anesthesiologist, I've done OB anesthesia before. What would you say to a woman who experienced intraoperative pain and they are now pregnant again? How would you counsel them on their labor and delivery, given that history?
So number one, I would say I believe you. What you experienced, it sounds horrible, and I'm really sorry that that was your experience. And how can we partner together to make sure that that is not your experience this time, that we can support you and that we can make sure that the outcome is different for you. And that includes the options of talking about, if you're motivated to have another neuraxial, what that might look like, how we might slow down and do the testing more adequately, how we might pause the surgery, how we can partner with our team members, how we can provide you anxiolysis if the situation just from being in the OR is things. So you give them a menu of all the things you can offer. Music, limited people in the room, partner in the room early. There's so many things you can do to make that experience different. The first words out of your mouth is, I believe you.
I also, just to add on to that, I think that conversation that you have is best done before they're there, the day of their delivery, the day of a repeat C-section. So if you have the capability of like a pre-op clinic or a pre-anesthesia clinic, these are great patients to get referred there, just so they can have that lengthy conversation about what their options are before they get there, so they already start in a much more positive way when they enter that entire site again.
Thanks. Dr. Zakowski, any final thoughts on that?
No, I agree. I do 95 or 98% of the high-risk consults, which are now like 4 to 5 a week. And it includes people who've had the bad experiences. So I agree exactly, which is my thing is, yes, that occurs far too commonly. I'm very sorry. Your experience wasn't what we wanted it to be, and here's how we can address it going forward. And it helps to calm it down. It does not make it go away. You just have to reassure them, basically, you have new things you'll do and that you will listen to them, et cetera, as Heather was saying.
But status post the podcast, I do a lot more elective general patients who've had bad experiences who come in and say, I do not under any circumstances want to be awake. That's an option.
Thanks, everyone. That's all the time we have. You're welcome to come up if you have other conversation points.